Welcome to the 8 Minute Rule podcast, where actual physical therapists share clinical pearls designed to create conversation around what's getting results in the clinic. No fluff, no Medicare stopwatch, only quality content.
I actually set a goal back in June. It was a very clickbaity goal. I'm going to Jefferson curl 225 pounds for reps or blow a disc in my back, whatever happens first by the end of the year. Spoiler, it's November 10th and I'm still healthy. I think I hit 210 pounds last week.
Welcome back to the 8 Minute Rule. We've got doing a little something different here today. We've got Alex with us, joining Drew and Mark, and myself, Jordan. What we want to do today is go through just a little bit of a controversial topic in kind of loaded flexion, Jefferson Curls. And Alex is actually on here to ask a couple questions and fire away a little bit differently so we can kind of dig through and just go through one evidence and then just strike up some conversations to keep going from here. However, as we always start with, we're going to have a little bit of an icebreaker here. So this one's going to be around lifting. And what I want to know is, what's one exercise you secretly hate but pretend to love because everyone else does it? Yeah, take a second. I'm excited to get Mark's answer on this, but let's start with Drew. What you got?
This is probably the one that I do a lot in workouts. I know, we both do F3, and the burpee or blocky man maker burpee those suck, and everyone always is like, oh yeah, more burpees, and I hate them. I still do them.
Yeah. And you lead with
people
them as
actually
well.
like burpees?
Do what?
People pretend they do and are like, oh yeah, let's do like a 200 burpees.
Nobody likes a burpee. They just like seeing other people in misery. And I think that's what it comes down to. So that's a good one.
That's fair.
Alex, what you got?
For me, it's probably bench press. I know, controversial. I have really long arms, so it's always been my weakest lift. I feel like I'm that meme of the elephant that looks in the mirror and sees a ballerina. Like, I want to be good at bench press, I want to like it, but it's just not me.
Yeah, I appreciate that transparency.
I'm going to make you feel better about yourself because I also do not like bench press.
Shocker, a kicker doesn't like bench press. Go ahead.
Wow.
Kickers lift?
I've been bench pressing for like 20 years, and I feel like I've almost met my physiological peak without assistance from steroids or other things, because my numbers just, they don't climb like they should, like any other lift, and I don't really know why, but there you go.
Well, to be fair, you do have much longer arms than I do. Mine's a squat. I hate a heavy back squat. I really do. And I do it because I know it's good, but I would much rather do deadlifts any day of the week than squats. Just my preference. Cool. Appreciate you guys playing along. All right, without further ado, Alex, why don't you take it away with the guest question and give us a chance to fire away on it.
Sounds good. All right, so today's topic for discussion is loaded spinal flexion, aka Jefferson curls, which I think it's an interesting topic. It's controversial in both the strength conditioning world and the PT world. And you have one side that will say, if you round your back when you lift, that's how you get hurt. And then you have the other side that will say, Wolf's Law, said principle, it's just a movement strategy, it doesn't matter. I think it's kind of funny because I think there's irony on both sides. On one end, you have the meme of people who deadlift really heavy weight, and they bend over to pick up a 45-pound plate, and they throw their back out because they never actually move in that position. And then on the other end, what I call the movement absolutists, who will say, yeah, you can do whatever you want, it doesn't matter. If you actually put their feet to the fire and say, all right, well, why don't you go pick up that heavy weight and Jefferson curl it, you'll see the fear kind of start to creep in their eyes because they believe the theory, but probably not the actual practice. Which brings us to our first question. I deem the spinal flexion litmus test. So for this one here, I know we tend to like things being in the gray in physical therapy, but we're going to make this as black and white as possible. So if you guys are getting uncomfortable, it's going to be just a yes, no, fail, pass, fail. So with this question, I think there's only one passable answer, and then two kind of questionable asterisk answers that you could go with. So, no further ado, we're going to do some imagination here. I want everyone to imagine you're walking to the gym, and there is a moderately heavy barbell in front of you. Obviously, it's going to be subjective to the person. Maybe it's 95 pounds, maybe it's 135, 245s in the bar. And I say, hey, Mark, Jordan, Drew, I want you to Jefferson curl that 10 times. What is the first thought that pops into your head? Go ahead and hold on to it for a second, and I'll go over, I guess, my scoring rubric here. So the acceptable answer is, okay, easy, I got this. And the two asterisk answers would be, I'll classify them to two different categories. So we'll call the first one more of a psychological gap. The first thing that pops into your head is, that sounds like a terrible idea. That's how you get hurt. My challenge would be, why do you think that? Is it because that's what you heard growing up? Have you had a previous back injury, never fully rehabbed, and you're stuck in that fear avoidance movement system? Or it could be something different. And the second fail would be, I just physically can't do it. And that's more of just an ability issue of, maybe there's a blind spot in your training program. Why aren't you strong in that position? Let's shine a light on that. So with that being said, who's up first? Who wants to go?
My initial reaction was, man, that's going to suck. But I think that I would be able to do it. I don't know that I would say it was, I think the first response, the acceptable one, was like, that was going to be easy. I don't know that it would be easy necessarily for me, but like I would do it without problem.
Nice.
Yeah,
I would probably have the internal battle. Go for it, Jordan.
Yeah, I was going to say for me, I think I have done Jefferson curls. I'm not afraid of them. I haven't trained them in a while, and so like for me, it would be a physically probably just can't do it. And for that reason, my concern would be that I'm gonna hurt a lot longer than I would like to in terms of I just need to build it up. Like I deadlift and I do strength and back, but I just haven't done Jefferson curls in a while. So I'm not scared of them. I've spent a little bit of time in the literature. Just physically, I'd need to train it, and I haven't been training it as much.
Yeah, I'm probably having the internal battle. I think the first thing, just because of the PT background and we look at mechanics and things like that, and historically we've heard you shouldn't lift that way. I mean, I think no matter what, that's one of the first things that is going to probably come to mind. At the same time, then I'm like, well, is that actually true? And what does the literature say? So I would probably like start counting the weight and be like, what is the risk ratio here of how heavy is this? How much do I think I could do? And have a reasonable risk ratio here of, do I think I have a likelihood of injuring it, or is it low? Because we can get into some of the research, and like no matter what you do, you're probably going to have some sort of risk, but is it the risk benefit ratio? Like, is it going to be helpful in the long run?
I like it. Does anybody else have anything on as far as the research? Anything they read recently? Bueller? It's okay if you don't. It's fine.
I don't know how recent it is. I know that there's conflicting evidence from what I have researched. There's like you can have injury. So when we're talking about that, like pain versus injury, like those are different things, right? Like we know that. And there's potential for injury. The higher one, based on not great studies, again, like a lot of them are either cadaver or animal based studies that I have seen. And it's, if you have a flex spine and you add a compressive load, as far as tissue injury, you're probably more likely to have some sort of a damage in that position. But that doesn't mean that's the only position that it occurs in. Like you can get tissue damage in a neutral spine as well. So my understanding is that it's not black and white for sure. There's a lot of gray area, and that's where I'm like, okay, what is that risk to benefit potential ratio?
I think that's a good point. There was a study they did somewhat recently where they took people doing like squats and deadlifts that were supposedly doing it in neutral spine, and they looked at the actual spinal imaging, and they found that I think it was like plus minus 30 degrees they were moving into spinal flexion, which, I get that side of the argument. You hear for some people that'll say, well, if you try neutral spine, you're going to flex anyway, so what's the point? But I think if we're talking about said principle, those people are probably adapting within that 0 to 30 degree range. And if you have someone who has no reference, no set point, and they start working out, and maybe they're working from 0 to 15 degrees one day and then 0 to 45 the next day, that's maybe when injury is going to happen. So I think neutral spine, don't throw it out completely. It definitely has its place.
I do think you bring up a good point. I think there's defining neutral can be important because there's a range, like not like, oh, there's one specific degree. There's probably a range, and maybe that's different for each person. Like you said, like, are you able to move and control it in that range? Do you have the body awareness to maintain it, or is it like just all over the place? Because we see the people who have no idea of how they're moving as well.
Yeah, I think it comes back to the common PT answer of it depends, right? I mean, when you're looking at this, what I've read, that repetitive lifting, especially looking more at job demands, right? Repetitive lifting is a factor of low back pain. And so we have to be aware of that. We have to admit that. But then we got to go back and say, so maybe it depends on who that is, because my stance has always been clinically, I've seen that if somebody's going to need to lift repetitively, we've got two options that healthcare tends to point them to. One, it's, well, change your job, stop lifting, or you need to get more robust and be able to lift better, lift stronger. And so I think what we've seen in practice over the years, and especially when I first came into working as a physical therapist, there was a big move of the biomechanics, and it's, lifting posture, position, and those things as well. And while we've seen that have its place, I think the research has continued to kind of push away that those things aren't actually as effective as we maybe thought they were, or somebody told us they were, right? And so, to me, it just comes back to it depends, because, if I'm training an individual that sits all day at a computer the exact same way that I'm training a manual labor lifter at a grocery store that's picking up 70-pound boxes all day long, then something's wrong. Like, I need to be aware of what the demands are at work and what they need to be able to do. And so I think it's going to depend on the goals that we're trying to achieve.
I think that's good. So next question here would be, I think a couple of you answered already. Do you personally do Jefferson curls? So for me, the current answer is yes. I actually set a goal back in June. It was a very clickbaity goal. I'm going to Jefferson curl 225 pounds for reps or blow a disc in my back, whatever happens first by the end of the year. Spoiler, it's November 10th and I'm still healthy. I think I hit 210 pounds last week, so I'm climbing steadily. Would I normally do it? Probably not so much. I think the real impetus for this was, Jordan might be able to attest to it. When I had my first kid, I started Jefferson curling her 50 times a day. I think I had sciatica within the first week. Obviously, a lot of other variables at play, lack of sleep and stress and all that. But I mean, if you have kids, you're J curling them all day long. And part of me wondered, if I actually trained this, would this have not been an issue? So that's what I'm doing right now, personally.
What kind of reps you doing for that, Alex?
So right now, it's very simple. Just once a week, 2 sets of 5. Just doing some linear, just add 5 pounds every week.
I currently do not train them. But I guess here in about a month or so, when I have a kid, I'll probably be doing some, 8 to 10 pound Jefferson curls quite a bit.
Yeah, I'm the same. I don't specifically train it and in a specific, I'm going to do this number of weight, but I'm also know that I'm not afraid to bend and lift. And when I'm doing other things, I lift with a flex spine a lot. Do I do it 200 and you said 220 pounds? No, I definitely don't. But my thought often is, and this is even with my patients, I've had patients do them. I'm usually going fairly light, and a lot of times I'm focusing on decreasing the fear around it. I've heard plenty of patients say, I was told I should never bend forward because that's awful for my back and I'm going to injure it. Well, no, not really. And being able to decrease that fear is a big one. But I'm trying to remember who it was that talks about thoughtless, painless, fearless movement. That's often my goal. And I don't know what the amount of weight that I lift up. I don't track it when in lumbar flexion, but it's not nothing. Heavy sandbags, weights, getting them ready. I'm doing it throughout the day, and I would not say that I'd be scared of it. Now, if I had 210 pounds and you told me to go do it, I probably wouldn't do it right now. But I might say, yeah, in so many months, I could probably get there.
Nice, I like it.
Yeah, I think.
All right, so on to the next one. Oh, sorry, Jordan, go ahead.
Jeez, come on, Alex. I lift too sometimes. No, I was gonna say, for me, Drew as well. Half of my workout in the week is going to be with F3, which is kind of like a boot camp style, any different stuff. And within that, I know that I need to be able to do stuff in plenty of different positions. The reality is, it's not going to be 225 in Jefferson curl range But I think for me, I've always tried to grapple with the resiliency model. I think our backs and our bodies are a lot more resilient, and that's what I teach, that's what I train, that's what I coach. I do enjoy deadlifting heavy, but from a Jefferson curl standpoint, I've always tried to look at the Stu McGill side of things as well as the other end of the spectrum, and the reality existing in is it purposeful? Is it purposeful for me to do a Jefferson curl with a really heavy weight? And in my life, it's not really purposeful. Like I haven't seen where I've needed to, and so to me, I'd much rather deadlift heavy. But it's also like Drew said, because I'm not afraid to roll my back. I'm not afraid to go into a flex position right now. And so I think there can be a lot that depends on it, but I do think that if I am potentially having back issues, would I go heavy Jefferson curls? I don't know. Probably not would be my answer on that.
Nah, I like it. All right, so on to more of the patient-facing question. How often are you giving Jefferson curls to patients? For me personally, it's actually not very often, primarily for two main reasons. First is the majority of my caseload is probably flexion-intolerant back pain. So if you start loading up sensitized tissues, it's just going to be a recipe for more issues. And if I had the right patient towards the end of plan of care, would I start putting them in? But the way with insurance and visits nowadays, by that point, if they're pain free, they're probably gonna be gone before I can put them more into that resiliency mindset outside of education. And the second would be more from a performance standpoint. So when it comes to deadlifting, if you have a neutral spine, you're gonna be able to lift just heavier weight just due to mechanics the way things are. So if I have grandma who's trying to help lift a couch and move it across the room, I want to give her the best tools available so she can do that. If we're thinking about injury from a perspective where, usually it happens when you exceed your tissue's capacities. If the ceiling is much higher with a neutral spine deadlift, I feel like you'd be remiss to not teach it to your patients. So those are kind of the two reasons I usually don't.
Yeah, I'd say it's not super common, but it all depends on what the patient needs to be able to do. So like if I'm working with somebody that's like a UPS driver or something like that, that's having to repeatedly lift packages, often the packages are bulky and not necessarily exceptionally heavy, but awkward to the point where like you can't really get into a full like deadlift position. So they're going to have to be able to bend and lift. And they're doing that all day. Before I discharge them, if they're coming for low back pain, like I kind of need to train them into that. It may not be my first thing if I need to calm things down or something, but I do need to do that eventually. But I don't often do it for similar reasons that you described there. I would say I am looking for, a lot of times if I'm teaching someone how to lift, I'm looking for coordination and activation as well, kind of the motor coordination classification. And a lot of times I'm trying to get things to coordinate and activate well together. I find that to be easier to do in a deadlift type posture or a squat position than like a fully flexed spine or even fully extended spine, like the reverse of that.
Yeah, I think for me, I would say that I probably use Jefferson curls quite a bit with my low back pain patients. It's just usually not going super heavy because to me it's almost more of a neuro-reed component to it, right? So, and I will say more times than not, I'm actually kind of starting more with the biofeedback on the table because most of these people just can't even get the starting point of it. Majority of low back pain that I'm going to see individuals that are athletic and I mean they're dropping down to the squat. Any of their flex position at the spine is going to be just going immediately into hyperextension. And so I'm trying to get some of that posterior tail. I'm trying to get some of that arch with that a Jefferson curl can do. However, if they got any weight to it, they're immediately going hyperextension. They just can't figure it out. So I usually am just fine, and I've got to start before there, re-educate, and Jefferson curl just kind of more of the down-train the system a little bit. And so that's to me why I go lighter with it. And then once they can do that, now I want to load them and see can they be able to tolerate a neutral spine if you want to, not being afraid of it going one way or another because it's going to at some point in their lift more than likely. And so it kind of just ends up fitting in more of a neuro-reed component.
Nice, I like it.
Yeah,
All right, so on to our next one here. Sorry, Drew. Man, I'm just jumping the gun here.
I was gonna say I would concur with like all of those. I'll add another perspective here. Yes, I train into flexion. Typically, do I do Jefferson curls and load them? No, not a lot. And I think one of the other things to make sure that we're keeping in mind as PTs with patients who are going through these, all right, the UPS driver, he's probably getting a lot of Jefferson curls all throughout his day. So if I'm doing that a lot in clinic, I do want to make sure that we're not doing way too much overloading. It's like the same thing with runners. Like you used to say, oh, runners, you're gonna have knee OA. Well, like, no, not really. It can actually be protective. Now, if you are, I think, a competitive runner and they're over 60 miles a week and they're doing it all the time, like you might be more likely to do that and you're not getting rest and recovery. So looking at the overall big picture of that patient and their life of, hey, did you come off a 12-hour shift where you've been doing a ton of lifting and maybe this isn't the thing we want to do today, but let's have the conversation and maybe let's train you on how to do some of these lifts on off days so that you can continue to build resiliency as long as you're doing well. So I think that's also a key piece into what we're doing programming wise, is looking at what do they have later in that day or what did they just come from as well. And that could limit what you're going to do as far as loading in that flexion position as well.
No, I think that's a good point. If you bring up volume management more or less, because if you have someone who does sit in flexion all day and most of their activities are flexion based, and maybe they don't know how to hinge, which spoiler is like half my patients, if not 75% of them, like you need to teach them a different movement strategy on how to hinge, flow those tissues, give them a break so they can move in more than one direction. All right, anything else on this one? Okay. On to the next one. Is there a right or wrong population for the Jefferson curl? Who's it great for? Who's it terrible for?
I mean, I would say the older individual that already has compression fractures, either that's diagnosed or undiagnosed, I think that's one I would be cautious about, but they still need to be able to bend over. I just don't know that I would load it much personally.
Yeah, I just think, piggybacking off that, the individual that when you're looking at their functional movement assessment, like how do they bend? If they pick something up without moving their legs at all and they just roll out the back, essentially doing a Jefferson curl, reaching down, then yeah, I can load that, but I probably need to be training something else, especially if they're having low back pain.
I can add a little bit. I think the softball is the one with the fracture concerns. That's easy. I'm not going to be loading it. I also think it's probably dependent on patient goals, what they need to be able to do. I do think it's worthwhile if someone has a lot of fear around bending, like how do we get them to be able to do it? And whether you want to talk about Jefferson curls and loading it, I want them to be able to do some sort of a flexion without fear, and that's going to be a big one. But if there is fear on board, I'm probably not going to continually load them. But I do want them to be able to bend and get used to it, and like it's going to be a long process. Are they going to be the one that sticks around long enough to progressively load it? Maybe not, but I do want them to be able to move and keep a healthy spine because we have to be able to move.
No, that's great. I think it's a good segue into next question. You know, how do we talk to these patients to get them not to be fearful of spinal flexion or just movement in general? Are there any strategies or, elevator speeches that you give to your patients?
One that I most commonly use is like kind of evolutionarily, we are designed to be bipodal and then bend over, pick things up like regularly all day long. That's what our spine was designed to be able to do. So it can be resilient and it's something that you should be able to do. Again, we just need to be able to train into it. So I usually use these words specifically, like this is a safe and healthy movement for your spine. And so that usually opens the door to like at least have a conversation about it.
Yeah, I think you guys have had plenty of patients that said they had low back pain 5 years ago and it got better and they don't have any problem with it now. And you ask them to pick something up and they just straight bend to the knees and don't move their spine at all, but they're all good. And so I think for me, it's just kind of the conversation around every time you move is a chance to just encourage your body to become more resilient. And if you are scared of a movement, there's going to be a problem that's going to come down the road if it's not already. And so, just really forcing your body, as Mark's saying, to be able to do the things it can do and do it well. And so if that's a certain way that you are terrified to move, then I think you need to consider looking into that and trying to train to that, because I haven't found somebody that cannot, even at a body weight standpoint, move in a certain way and train that to at least be resilient. And we know that that's going to help them decrease injury down the road as well too.
I think it's important to understand what they're fearful about, because I've had patients who are fearful that like, oh, it's just going to hurt. I've done this before and it hurts. And then we can educate them about pain. What does that mean? Talk about tissue damage versus pain. Or we have people who are really fearful of herniating discs. And then we can start to pull out some of the literature around people have herniated discs all the time and they don't have pain and they are fully functional. So knowing what their fear is it that they're going to hurt? And how do we do some sort of a progressive movement into it? Like, okay, we want to be able to move. Let's start here. Let's start in a quadruped or suspended position to where you can do it. And oftentimes that feels better because they haven't moved into flexion and they're like, oh, that does feel kind of good. Okay, so now we just have to teach you how to build up the resiliency and be able to do that into a standing position now. Or if it's like they are very fearful of pain, then we can teach them like that doesn't necessarily mean that there's tissue damage. And how do you move through that? What's acceptable, what's not? So getting their perspective on what is fearful is probably the first step that you need to take.
No, those are all great there. And just for the listeners, 225-pound Jefferson curls is not a normal goal. Like patients aren't going to want that. Only crazy people do.
You're a beast.
I think Drew brought up a good point. I say it all the time, especially people that come in. I hear this often, like, oh, I had a herniated disc 10 years ago. And I actually bring up that study and show them the chart of positive imaging findings in asymptomatic patients where you can see, like, yeah, you're 70. Well, there's probably a 70% chance you're going to have something wrong with you, but you're not in pain. And that with education, that disc and other things can heal on their own over time is definitely powerful for patients.
Stories are also powerful. Like,
Are there any
I know
other
another
questions?
patient.
Yeah.
I know another patient who was just like you. He had this, and here's where we go. Like the stories are sometimes more powerful than the studies, or it can open up questions like, really? How does that happen? And then you can bring up studies. But it kind of depends again on that patient and what they're going to respond to better so that they understand it better. Like getting it in their bones and not just like, oh, I know this, but really understanding it.
So I'm hoping you guys can use me as a case study. You could be like, I know someone, you could probably at least Jefferson curl 210 pounds before you get hurt.
I love it.
Scientific.
Yeah, from the
case
performance
study.
standpoint, Alex, what have you seen solid gains in your deadlift off of this?
Can't say I have. Ironically, I feel like I tend to get more dinged up deadlifting heavy than I do Jefferson curls. Maybe I'm just I feel more confident pushing the needle on the deadlift versus a Jefferson curl. But I think it's more of a mentally empowering thing where my new favorite pastime is just pick things up in the worst way possible because I know I'm probably not going to get hurt. So I think I've seen progress in that where I don't have to think twice about, all right, let me get set up in my form. I'll just do it now.
Can I ask you how you came to 2 sets of 5 one time a week?
I can't say it's super scientific. I mean, it's on just the very low end of just, a 3x5, but just a back off set. So usually I'll do like my normal deadlifting routine and then this is small volume added. So I don't know if there's any really best practice of, if you're going to do Jefferson curls, how often, how much volume should you do? If you do it concurrently with deadlift, should it be 50-50? I'm kind of more in like the 80-20 rule. We'll throw a couple sets just at the end.
Awesome. Well, good stuff. Alex, I appreciate you coming on. We got to do this again sometime.
Yeah, no, it's been a blast.
Do this again sometime. Anybody give some feedback to us if you want. We'd love for more discussion to come from this as well too. So it's been good.